So, as I said, the objectives, we're going to try to review the advances in hearing rehabilitation, what's been happening in the field of otology in terms of hearing over the past 10, 20 years. We're going to talk also about what's been happening on the vestibular side of otology and neurotology in the past couple of decades. We're going to try, as we do this, to kind of look ahead, see what's coming down the pipe, where the future is going to take us as a specialty and a division. We're going to review some of what we do already here at CCF and where we think we're going to be going in our programs. And for residents in the room and my colleagues from other divisions, yes, this is unabashedly a recruitment pitch for residents to join otology. So it's on. This is a quote I like. I heard it once. I thought it was overrated, but I think as we all practice more and more, we realize that it is true. This is David Sackett. He's considered the father of evidence-based medicine. And what he says essentially is half of what we learn today, whether as med students, residents, or even in our practices, in 5 years will be either completely wrong or pretty much out of date. So 50% of what we know will not be correct in 5 years. The only problem is today, nobody can tell us which 50% that is. What that means, not to be pessimistic, is of course, this is the basis for continuing medical education. That's why we all learn all the time, keep updating ourselves all the time. But it also means, and I'm going to highlight this through our talk today, is in your practice, in your everyday encounters with patients, with new technologies, do not dismiss an idea outright. Think about it, think of what merit it has, explore it, analyze it, because you would be surprised. And I listed a few examples, and we'll see during the presentation. So ear tubes and water exposure. When we were residents, it was the dogma that any kid who gets ear tube does not get in the water as long as they have the tubes in, because it was, risk of infection. Within a couple of years, the new recommendations came out, probably it was the 2005, 2006, that said, well, they can actually surface swim. Nothing changed, but somebody just thought, well, let's look at the pressure, let's look at the physics, and then realize that really, if you look at the evidence, there is no significant increased infection risk from tubes. So we went from complete dogma and absolutely no water exposure to it's okay to swim. The other example I like, osseo-integrated implants. We'll talk about this in a little bit in bone conduction devices. But basically, Brennemark is the physician or the scientist who came up with the idea of osseo-integrated implants in the late 50s. His idea was so revolutionary, he was kicked out of the university. He was told that what he came up with was completely crazy, that nobody should be doing that. And he literally was kicked out of the university. He lost all his funding. He ended his life in misery. And, God knows how many people have osseo-integrated implants. Many of us here in the room probably have some dental implants, and then, of course, in our field, the bone conduction devices. Cochlear implants, you'd be surprised to know, were fought very, very, very hard. So people who started doing cochlear implants were accused of being unethical, immoral. What were you doing to kids? What are you experimenting? And then, of course, now it's standard of care. And we'll talk about how things are moving forward in this field. So let's start with hearing loss. And on the diagnostics front, there's not much that has changed in the concept of the tests that we use every day, right? We still do our audiograms, we still do our ABRs, we still do our speech testing. We have some modifications on all of that. But what really has changed is we have obviously newer technologies. And as we understand those newer technologies, our candidacy criteria for who benefits from these technologies evolves over time. I like history, and those of you who have spent some time with me know already that I like stories. This is a picture from one of the very, very first human patients to be implanted with the cochlear implants. In the corner, in the brown shirt with the white Italian color, is Dr. Bill House, and in the blue shirt is Jack Urban. He's the engineering counterpart who helped him devise the implant. And this is one of the very first patients fitted with a single channel implant in the late 70s, early 80s. At that time, they stimulated only at one point. And the idea was if you're profoundly deaf, that can help you with sound awareness and that can help you with lip reading. And then within a few years, in the first 5 years of the 1980s, people started thinking, well, why limit ourselves to only one electrode? Let's look at more than one electrode, multi-channel electrode. Surprisingly, 3 of the big 4 groups that were competing in that field were in California. I don't know why, but it was Bill House in LA, it was Simmons in Stanford, and it was Merznick in University of California in San Francisco at UCSF. And at the same time, there's Graeme Clark pictured here in Australia, who is considered the father truly of the multi-channel electrode, and he is the brain behind the Cochlear company. This is the first multi-channel implant, the Nucleus 24 down there. Um, over the past 30, 40 years now, 45 years of having cochlear implantation, their criteria for candidacy have evolved dramatically. And this has paralleled essentially the evolution in technology. Obviously, the technology of the cochlear implants have changed. Programming, we better understand programming. We better understand what patients want. Not long ago, actually, maybe less than 20 years ago, when I was just starting my residency, if you looked at the engineering side of cochlear implants, and if you looked at what were they extracting, there was a big debate. You know, if you look at sound is very complicated, and you can't give all that information through an electronic device. So we were looking at, well, do we look at the envelope of sound? Do we look at certain frequencies? And you know, when I was doing my research initially, we were looking at all these fast Fourier transformation and very complicated physics formula that I don't remember right now. But basically, to say that the field has gone through a big evolution until we really figured out what has worked over time. And of course, in parallel, with surgeons, it's the surgical refinements that have taken place over time, and we'll address that in our talk today. The main thing you will see between cochlear implantation in the field of cochlear implantation is that there has been a lag between practice and regulation. And I say that to the residents, especially in the room or online. When you look at the indications online on paper, they are a bit different from what most cochlear implant centers are doing today. And the idea is, as you know, the FDA and Medicare, they're fairly conservative with their criteria. So they kind of lag behind. They wait to see what we're doing as we push the envelope more and more and see which patients, who we thought just a few years ago would not benefit from a cochlear implant, actually benefit from a cochlear implant, and that changes. This is by no means exhaustive, but this is kind of to give you an idea of how things have changed. In the 1980s, it was essentially patients with bilateral profound sensorineural hearing loss, so patients who were completely deaf. By the late 1990s, we went to moderate to profound hearing loss and up to 40% in open speech recognition. In the 2000s, now we're up to 60% in bilateral conditions and 50% in the ear to be implanted. So you can kind of imagine a little bit how we've gone from completely deaf, no sound perception at all, to patients who would do pretty decently on many tests, but we know that they could do better with cochlear implantation. This is also an illustration of the FDA labeling, and you see that they are different for every device. So again, when you look at these criteria and you look at this and you're like, oh my God, how can I keep up with it? It is confusing. It changes over time. But again, experience is what helps. This is kind of a simplified way to think about it. This is from the Cochlear website. This is the standard, if you want, candidate today for a cochlear implant, somebody with moderate to severe hearing loss with 60% discrimination in the best aided condition and less than 50% in the ear to be implanted. Now, as we moved along in the field, people started asking, well, what about patients like this, right? Patients who have good hearing in the low frequencies, but really, really bad hearing in the high frequencies. And these are patients that kind of fell through the cracks. And, they came to us and we said, well, you don't qualify for a cochlear implant. Let's give you a hearing aid. But the hearing aid doesn't help you either because, the high frequencies, they're completely gone and we can't help you with a hearing aid. So people started thinking, well, what do we do for these patients? And if you remember the cochlea, well, I hope you remember the cochlea, the tonotopic distribution of frequencies, there are high frequencies. Can you see the pointer over there? Yeah. The high frequencies at the basal end, the low frequencies at the apex. And these patients, they do well with the low frequencies, they're not doing well with the high frequencies. So again, anatomically, this area is functioning well. This area is not working well. And people started thinking, this work mostly came out of the University of Iowa, was what if we used shorter electrodes? What if we put electrodes in the basal turn that covered this part that is not receiving proper acoustic stimulation, and we left the apical turn to be acoustically stimulated? And indeed, they did devise shorter electrodes. This is the shorter, initial hybrid electrode from Cochlear compared to the standard electrode that is about 4 millimeters longer. That's quite significant. That's about 25% longer. And they used it successfully. And now we talk about electroacoustic stimulation in these patients, where we use both electric stimulation and auditory stimulation, depending on where their frequencies are. The electrodes have changed a little bit. We're not going to review all that now, but the concept still holds. Moving on to single-sided deafness, I think there's an expression in the older generations, older than us, that says, do you remember where you were when you heard that Elvis had died? I don't know if you've ever heard that, but I learned that early on. But basically it says, when you hear a news that is so shocking, you remember what you were doing that day, even if it was 20 years ago. And is Ben in the room? There you go. Okay. You know what that is. That's hometown for Ben. This is Antwerp in northern Belgium. And I do remember where I was sitting in the auditorium at the university in Antwerp in 2009 when I heard this physician. This is Dr. Paul van de Heining, who's at the UZA in Antwerp. When he came on stage and he said, "Let me tell you about the patients we're implanting with deafness on one side and normal hearing on the other side." And I was sitting, and my senior partner was sitting to my left, and I looked at him, and we were both like, what are they doing? This is insane. This is crazy. You know, you should not be implanting patients with hearing on one side and deafness on the other side, because the brain cannot mix electric signals from one side and the auditory signal on the other side. Well, turns out we were wrong, right? And everybody was wrong at the time. And the reason, to be fair, they were doing it to help with tinnitus, because we know that patients who have severe tinnitus and severe deafness, once you implant them and you turn the implant on, the electrode stimulation on, that electrical stimulation reduces the tinnitus. So they got a bunch of patients, I think there were 15 in the initial study, and they said, look, you're not going to hear, but we're going to give that implant to you, so because we can't do anything else for your tinnitus, and let's see how that tinnitus how that implant works. A year later, a lot of these patients came back and said, we love the hearing. We've got binaural hearing now. We've got hearing on the other side. And so they started doing, and they started publishing. And you see, these papers are from 2008, 2009. And this is a little PubMed search. And there was nothing about single-sided deafness. 2008, 2009, the world watched for about a year, and then suddenly it exploded. Now, pretty much single-sided deafness is standard of care. And that, again, is not long ago. That was at the beginning of my practice where, we went from the dogma is you do not implant patients with hearing on one side to, oh yeah, this is, of course, these patients would benefit from it. What about the surgical technique? The surgical technique has also shifted towards, more hearing preservation, more cochlear structure preservation, and better understanding of how we do things better. This is a mastoidectomy. You guys remind me to share this picture with you. I always share it. This is good anatomy. So this is a mastoidectomy, obviously in a temporal bone. This is the traditional approach to a facial nerve, for cochlear implantation, through the facial recess. This is the facial nerve. This is the chorda tympani. That's the horizontal semicircular canal. You see the pyramidal eminence right here. You see the promontory and the round window over here. And again, not long ago, less than 20 years ago, what everybody did was a cochleostomy. Basically, you drill that lip a little bit, you open the bone in front of it, and you put your electrode in there. And the idea was early 2000s, 2001, 2002, just get the electrode in there. Just get it in there and let it stimulate. They all do well. But then people started asking, well, why are we having so much variability, right? Why are some patients doing great? Why are some patients not doing that well? We looked at age, we looked at duration of deafness, we looked at previous amplification, we looked at the patient's motivation and rehabilitation, we looked at their cognitive status, we looked at the device, all these were actually important factors, right? And manufacturers loved it because they said, look, our patients are doing so much better than their patients. Truth is, everybody was doing pretty much the same, in terms of device and electrode. But one thing that we started noticing, and this is about 2004 this paper came out, they looked at the position of the electrode in the cochlea and they said, could that matter? And it turns out, of course, it does matter. So in patients where the electrode stays in the scala tympani, where all the dots are black, and then it goes perimodal, it goes close to where the nerve cells are, these patients did much better. So the field started thinking, okay, well, how do we get the electrode in there? How do we make sure that the electrode does not cross from one scala to another? And how do we make sure that we don't traumatize the structures? Again, this is a survey from 2007 from Dr. Adunka, who is now not far from here, and Dr. Buckman. They were both at the time at UNC. And the discussion was, well, which cochleostomy is better? Do we do the cochleostomy inferiorly? Do we do the cochleostomy superiorly? How big of a cochleostomy should be? And one thing you learn with time is if you want to solve a problem, you just ask a different question. And the question, at that time was, is there something else that you could do? 84% of otologists at the ANS, the American Neurotological Society at that time, said, no, cochleostomy is the way to go. 16% said sometimes, maybe we thought about putting it through the round window. Now, interestingly, when Bill House started their implants initially, they put all the electrodes through the round window. But somehow during the course of surgeries, somebody decided it was better to put it through the cochleostomy, and it became the dogma. When I was a fellow, we looked at the temporal bone collection at the house clinic, and we saw patients who had the cochleostomy. So this is, you see the bone is drilled out here, the electrode is implanted, and we saw a lot of fibrosis because the periosteum is breached, so it induces an inflammatory reaction. And you see, this does not look pretty, right? And you can imagine that with the electrode in there, you cannot stimulate things properly. As opposed to patients where it was just inserted. This is one of the old patients from Bell House. If you just open the membrane and then you insert in there, pretty much pristine, right? I mean, obviously these are, these are the extremes, but very little damage when you insert it through the round window. And then, of course, again, suddenly round window became the normal thing to do. Round window became what everybody did, right? And we went from which cochleostomy to why are you still doing a cochleostomy? Another technique that is, picking up steam also is the ECOG. And the ECOG, as a reminder, we'll talk about it in the vestibular part of the talk also, is essentially a measurement of electric potentials in the cochlea. There's the summating potentials, there's the action potentials, there's the cochlear microphonic. We'll discuss this. I think I should be giving you residents a talk about vestibular evaluation and testing, but these are different components that you look at. And then cochlear microphonic is the big one as far as cochlear implantation is concerned. So traditionally, ECOG has always been linked to Meniere's disease. If you have Meniere's disease, you can ECOG if the SPAP ratio is over 0.4 or 0.5, depending on what your testing material is. Then you say this patient has probably has high drops. And then people started thinking, what if we use those intracochlear measurements during cochlear implant surgery? And it turns out that you can do that. As you're advancing the electrode, you can stimulate electrically, and you can record electrically on a different electrode, on the array, and then you can get these different waveforms. And it's essentially, if you think about it, you're pushing that electrode slowly through the cochlea. You're checking on the structures. It's like, hey, how you doing? We're good. Okay, we keep moving. How are you doing here? We're good. We keep moving. Once the cochlear microphonic drops, then you stop. You think maybe you've got trauma, or maybe you've passed the area that you're interested in. This is a field that's also evolving. This is something that pretty much came up, started about 10 years ago, but this has been the talk recently. We don't need to do it in every single patient, but if we're doing hearing preservation, if we're really looking at ultimately proper positioning of the electrode, this is where the field is going. Something else, we thought, okay, well, we know how to get the electrode in the scala tympani. We know how to minimize the trauma. We know, some techniques that guide us. But what about if we try to reduce the variability? And these two slides are courtesy of a company called Iota Motion, again, from Iowa, which is a big cochlear implant center. On the left are forces in the cochlea by manual insertions, right? We all think we're fantastic surgeons. We all think we're perfect, and we can just put the electrode in perfectly and then advance it at the proper rates, as opposed to a robot. Who wants a robot in surgery, right? But the robot seems to cause a little less trauma. And if you look at the human insertion, by the way, this is moving. Right? On the right side, it is moving. It's just very slow. It's 0.1 millimeter per second. I doubt any human can advance consistently at 0.1 millimeter per second. Now, you could argue that this is a bit too slow. You can go to 0.2, 0.3. But look at how this electrode is moving here. And you'll see here as it advances, and it requires some patience, something not, as surgeons, we're not very well known to have. It is, I've played with this device, and it's just, you got to just wait. But it goes in very smoothly, and you can feel the resistance. Whenever it hits resistance, it slows down. And and this company actually has shown this. Iota Motion is from, I have no interest, of course, but they have shown that they can reduce dramatically the forces in insertion. And there were studies already previously that shows that if you introduce a bit too fast, you're building pressure, because remember, you're not introducing in a vacuum, you're introducing in liquid, in perilymph. That perilymph gets pushed, you can destroy the structures. So, again, another possible improvement. This is the device that they have. We are looking at acquiring it here and potentially running some of the early studies. There are just a few centers around the US that are using it now. Summarizing a bit on cochlear implantation, we do a lot, right? And we don't do enough. So in 2015, only 170,000 people in the US had received implantation. That's really not a lot for almost 40 years of implantation. And if you look at the traditional criteria that we talked about, the old, more conservative criteria, we're only serving 12% of the population. If we look at the new criteria with residual hearing and with single-sided deafness, we're down to 2%, probably less than 2%. So we've got a lot of work to do to properly get that technology to the patients who need it. And if you look at the new criteria, that we're looking at about 2.5 million adults. I'm not even mentioning peds here. 2.5 million adults today in the US need a cochlear implant or would benefit from a cochlear implant. I shouldn't say need, right? So, our hearing implant program, it's amazing. Let me tell you, I've been in different places around the world. Last year, we've done over 150 implants. Our target for next year with the addition of 2 new otologists is ideally 250 implants. Right? That means not just more operating time, that means optimizing the performance. We're working on that as a team. The team has gone on a retreat recently. We've done a lot of work to try to optimize, to just take out to trim the fat from our process, because it's seeing the patient, getting the patient evaluated, having the patient select the device, meeting with the surgeon, having the surgery, having the programming. So there are a lot of meetings. So if you go up from 150 to 250, that's with several hundred more meetings that, or clinic appointments for the patient, for the entire system. And, let's dream big a little bit, #505. So why not reach 500 implants per year in 5 years, right? I did clear this with my partners so nobody can have a heart attack. But it is feasible. There are centers that are doing 400, 500 implants a year, right? Obviously, it needs, again, optimize the performance, optimize the system, but it is definitely within our reach as, the Cleveland Clinic system. And that's just here in Ohio. Just to summarize before we move on, who do you refer? If I haven't confused you enough, keep it simple. There's the 60-60 rule that we're now following. If you see a patient with a pure tone average above 60 decibels and less than 60% word recognition in one or both ears, it doesn't mean that both ears have to be bad. Send them over, right? Also, if you see patients with numbers that are better than this, but they're not doing very well with their hearing aids, send them over, right? I've seen many patients who come in, they were referred by somebody for cochlear implantation. They come, our cochlear implant team, fantastic team, implant audiologists, they look at them, and all it needs is tweaking of their hearing aids. We give them better programming of their hearing aids. So no matter what, they will leave the appointment better, even if they don't qualify for cochlear implants. A quick detour by bone conduction implants. We're doing good on time. So again, we've talked about osseointegration and the story of Brennemark. This is a close-up view of what a titanium implant looks in the bone. The idea, common indications, obviously single-sided deafness. When patients don't have hearing on that side, you put the bone-anchored device and it transmits the sounds through bone, through solid, which is almost zero attenuation to the other ear. Also conductive hearing loss, or sometimes even, sensorineural hearing loss in this ear, but they cannot use a hearing aid. One of my patients coming up is a candidate like this. They just cannot, for a variety of reasons, use a hearing aid. A bone conduction device works. The grandfather of bone conduction devices is the Baha from Cochlear that was introduced in the 80s, if I'm not mistaken, or 90s, my pardon. It's an implant, an abutment, and the processor. It's a percutaneous device. It has to go through the skin. When we did them initially, we raised the flap. We had a special small dermatome that we just raised the skin flap, and then we cleaned removed all the subcutaneous tissues, and then drilled and put the implant and put the flap back. We got this. That wasn't pretty, right? A lot of patients, alopecia, sometimes infection. That skin was too thin, so we changed the technique. We went to a linear incision. We made a linear incision, trimmed the things a little bit under it, and then put the implant percutaneously. And nowadays, this is the Ponto. This is the device that we use here in our center. We do a single procedure. I think, if I'm not mistaken, it was either Dr. Woodford, not Woodford, Woodson. Thank you. I was like Dr. Woodson or Dr. Aaron, who timed one of their surgeries at 3 minutes and 38 seconds of this, right? You just punch it, you put this guide, you drill, you do the countersink, you put the implant, you're done, right? So the technique has evolved a lot over time. The other thing that changed is a few years back, Medel came with an implant that is not percutaneous, that is transcutaneous. So there is a device that is under the skin. and there's the processor that's outside that attaches magnetically to it. It looks a little bit like a cochlear implant on this side, and this is an active, transcutaneous device. So the vibrating component is actually under the skin. Initially, Cochlear responded by having, this Baha attract, which involved a larger magnet and under the skin, and then still the device on the outside. And then recently, they came up with the Ossia, which is kind of the similar concept, using the same implant and a device that's under the skin, and then transcutaneous transmission. Part 2 of hearing loss is something I feel like we need to address and have some knowledge of as otolaryngologists: hearing loss and dementia. Social media loves it, right? And we always have known that, hearing loss increases isolation, affects your cognitive load, potentially leads to more depression and probably more dementia. But in 2017, this was kind of the landmark. The Lancet Commission on Dementia Prevention, Intervention, and Care identified hearing impairment as a modifiable risk factor for dementia. And they said that if we handled hearing care, we would reduce the risk of dementia by about 9%, 10%. Not bad as a number, right? And the reactions then varied from, what are we talking about here, to, some hearing aid companies loved it, and we went to, you got to buy our hearing aid, or you're going to get dementia. And so as the field, we kind of had a moral duty to figure things out and say, it's not this. It's not if you get hearing loss, you're going to get dementia. This is not a one-to-one. This is not a causal relationship, right? It's an association. And it looks probably a little bit more like this. This is a connection between age-related hearing loss, cognitive impairment, depression. It's two-way or a three-way relationship between all these elements. And yes, definitely using hearing aids helps. Definitely using hearing aids reduces your cognitive impairment. We've all learned of listening fatigue. It probably reduces your depression because you're not isolated. You're not sitting in the corner at family events. You're not, unable to go to your social events. And there is now evidence that shows that the use of hearing aids does reduce dementia. This is a large trial that came out not long ago, a multi-center trial, specifically in patients with high risk for dementia. Using hearing aids definitely help in reducing those risks of dementia, right? But, the Lancet was not to be outdone. And once we started settling the dementia question, a week ago, I get an Instagram forward from one of my friends. And that said, did you see what the Washington Post just released? And of course, the Lancet said, why limit ourselves to dementia? Let's go to mortality. So now we have this paper that says if you wear hearing aids, you are 24% less likely to die in 10 years. We can discuss this paper. This was just released not long ago. I pulled it out because I was like, oh, come on. And basically, this is a population study. How they define regular use of hearing aid is relatively loose. You could wear it sometime, at least sometime. And there are a lot of questions, right? So you can think that patients who are wearing their hearing aids already have access to hearing aids. So they probably have better access to care, right? So that alone is a possibility. And they do mention that in the paper somewhere hidden in the depth of the discussion. Or if you're wearing hearing aids, it means that you're somebody who actually cares about your health. And so you're going to take care of the other components of your health. Again, we should recommend hearing aids to everybody. We should encourage patients to use hearing aids, properly programmed, properly fitted hearing aids by an audiologist, but like somebody like our team. But we should also be careful, and this is a discussion that we're all going to get from our friends and families and cousins about, well, is it true that if I wear hearing aids, I'm less likely to die? And we're not quite there yet. I wish we could give hearing aids to everybody, and they say, we just saved your life. I'll take a pause. That's where I grew up. Questions about the hearing before we jump into vestibular? Yeah, you guys are eager to get to the dizziness part, aren't you? So vestibular, this is part of something I really like. 60 to 80% of the diagnosis is still the history. So you should, by the end of your discussion with a patient, pretty much have an idea of what the diagnosis is. But let's go over what's been happening over years. When I was a resident, that seems longer and longer every time I say it. But that was almost 16 years ago. We only had VNG, right? We had also some centers had the rotary chair. Others thought it was too expensive. ECOG was kind of in and out. It was interesting at times and kind of suddenly faded. And then suddenly, within a few years, we had all these other tests that showed up that became part of the mainstream. Video head impulse testing, vestibular evoked myogenic potentials, subjective visual vertical, subjective visual horizontal, dynamic visual acuity. It became, the vestibular lab became this hugely expansive, with an A, and expensive place to set up, but it really changed the field. And of course, there's computerized dynamic posturography. Again, I'm not gonna get into a deep discussion of this, but I want to highlight some of the tests that we have here also, and explain why this is important, how this works. So basic subtests of the VNG, as a reminder, there were tests that look at the oculomotor system, and tests that look at the vestibular system. And the people, when they think VNG, they think calorics, but that's only one of the subtests. But a caloric is just irrigation with cold and warm air, or cold and warm water, and then warm water causes stimulation and excitation of the horizontal semicircular canal, of the ampulla here, and the cold stimulation is inhibitory, and then you get this very dizzy patient who hates you for about 2 or 3 days after that because they got really uncomfortable with the tests. But the VNG was not enough, right? We all knew the VNG was not enough. That's all we had, and patients came back sometimes with a normal VNG, and we said, your test looks normal, and they were clearly dizzy, right? They're not. This is not a psychogenic component, and it's not normal for a couple of reasons. One of them is, as you saw in the previous illustration, the calorics mostly look at the horizontal semicircular canal. And you know, we have the posterior semicircular canal, we have the superior semicircular canal, we have the utricle, and we have the saccule. So it was only testing 1 out of 5, of the organs of balance on each side. Also, the caloric irrigation is a stimulation at 0.003 hertz. And if you know some physics, that's a very slow movement of head. The natural head motion is between 0.05, so at least 10 times faster, to 3 hertz, so that's 1,000 times faster than what caloric stimulates. Right? And so sometimes patients would say, I'm dizzy, I move my head and I'm dizzy, but your VNG is normal, your calorics are normal. Well, yes, of course they're normal, because they're testing something that's aphysiologic. Rotary chair did a little bit better, but again, rotary chair, tests both ears. It's not exactly, it doesn't show you one side or versus another. It might in some protocols, but it wasn't ideal and optimal. Enter the video head impulse testing. It's based on the head impulse test that, it's an activation of the vestibulo-ocular reflex. And basically, I hope the camera works here. So basically, patients wear goggles with either an integrated camera, or in some systems, the camera is in front of them. You ask them to fix it on one point, and you do what are impulses, head impulse. And as they're fixating, you're trying to catch saccades, okay, which basically is showing you that the vestibulo-ocular reflex is not working fast enough, and that the patients have to compensate, but to keep their eye on the target. You can do it. Okay, that was the horizontal semicircular canal. The advantage is that you can also test the other 2 canals depending on how you position the head and how you do the head movements. All right. This is left anterior, right posterior canal. So remember, these are paired. The anterior and posterior the anterior on one side is paired with the posterior on the other side, and you can do the other side also. Okay, stop. You get a graph like this. Horizontal semicircular canal, you get the amplitudes, you get the gain, right, with normative data. This is right horizontal, left horizontal, right posterior, left anterior, right anterior, left posterior. And in somebody who has a weakness, this is normal results. This is somebody with a weakness. You see that the gain is very much reduced. This is the head movement. These are the eye movements, and these are the saccades. The patients are trying to catch, to move their heads, their eyes fast. And this was beautiful because it was digitized. This is what we call overt saccades. So this is the head movement. You move their head and their eyes move. That's something we could potentially see in clinic. We couldn't see these. These are the covert saccades. These are the saccades that are moving, that are happening as the patient is moving their head, right? The vestibular system, the nervous system is very fast. And so we were missing these, and we were missing a lot of the information. And now suddenly we have a way of testing the different semicircular canals. We move on to VEMP, vestibular evoked myogenic potential. This is the otocyst. This is a primitive organ that worked mostly for balance, no hearing. But even the initial, the balance organs are stimulated by sounds, because remember, sounds are pressure waves, and then if you push enough on any organs, it's gonna, stimulate. So we know that the utricle, if you stimulate the utricle, you get, movement in the eyes, in the extraocular muscles. Again, this is a very rough description. If you stimulate the saccule, you get stimulation of the vestibulo-colic reflex, neck. This is the sternocleidomastoid. So basically, we have the C-vamp, the cervical vamp that tests the saccule, and we have the OVAP that tests the utricle. And we went from we're testing just the horizontal semicircular canal with one test that's aphysiologic to we're testing all three semicircular canals, and we can compare the different testing modalities. We're testing the utricle with the OVAP with the subjective visual horizontal. I didn't talk about that. We're testing the saccule with the CVAP and the subjective visual vertical, and it keeps changing, it keeps growing. Every year we hear of new modalities, of new ways to play around with these tests, of these parameters. It reminds me very much of the early days of cochlear implantation, how people were looking at the physics of things differently. In parallel, over the past 20 years, and this is, it's sometimes taken for granted now, but 15 years ago, it was a bit of a guessing game. We only had criteria for Meniere's disease from the American Academy. We heard about vestibular migraine. It was like, well, I don't know, this patient may have vestibular migraine. And then the Berenice Society was this is the International Society for Vestibular Disorders, basically put together a few task forces, and now we have very clear criteria. Are they perfect? Probably not. Are they going to change? Definitely yes. But at least there's a guidance. Now we know who to call a patient with vestibular migraine, who to call a patient with obviously vestibular paroxysmia, Meniere's disease, mal de débarquement, orthostatic dizziness, right? Bilateral vestibular weakness. Again, not perfect, but that helps a lot because if we define things the same way, we can do research, we can understand better, and we can change things as we go. What is this? Vestibular implant. This looks like something that somebody made in their garage, right? Because it does actually. This is a cochlear implant from Medel. You see, this is the intracochlear array. And basically they diverted 3 of the electrodes to stimulate the posterior, the lateral, and the superior canal. It's always been in the talks. It's like stem cells, right? We've talked about stem cells for hearing for years, and then they never materializes. But this is almost there. I was at a meeting exactly 1 year ago in March, actually last year. There's a lot of talk about this, right? And it's pretty exciting. So, and there are different philosophies about this. This is the concept where you stimulate the semicircular canals, and there's another group that's working on stimulating the otolithic organs. You see the electrode here. This is the cochlear implant. This is the electrode that goes towards the utricle and the saccule. So again, we're still learning. We're still trying to figure things out. This is a patient who would get a cochlear implant and a vestibular implant. This is the round window insertion for the cochlear implant. If you go through the stapes sits on top of the saccule and the utricle, not the cochlea, depending on what part of the stapes you're in. And then you can actually stimulate the saccule and the utricle. These are, again, preliminary results, right? This is the patient before. That's their center of gravity. These are taken from a dynamic posturography testing. Basically, you see that they're all over the place. When you activate the implant, pretty decent, right? Now, these are patients with bilateral vestibular loss. Patients with bilateral vestibular loss are probably the most miserable patients on the planet. They cannot walk, they cannot move. Any movements they make, the entire world moves around them because they have no stabilization. So this is huge for these patients. It's still experimental. There are still, research criteria that are being defined. And currently, as we said, it's limited to patients with bilateral vestibular loss and severe chronic vestibulopathy. But it's coming. There are now studies in animals which show that even if you've lost your vestibular system, years ago, they did these labyrinthectomies in monkeys, and then a few years after that, they actually inserted those electrodes, and they could still stimulate the vestibular nerve ending. So there's hope for our patients with, severe unilateral loss that have never compensated. So it is the next frontier in neurotology, along with advancing cochlear implants. It does, as you can tell, require a very strong integrated multidisciplinary program, something like we have here. You need excellent testing. You need somebody who truly understands the basics of physiology to be able to give you a better understanding of what's going on. You need, surgeons obviously who are comfortable with that. You need neurologists on board. We work with the neurologists. You need physical therapists to help you rehabilitate these patients properly. You need physiologists, people with electronics, etc. So this is going to be the big centers, all right? The big education and research centers. There are currently 4 places that this is being looked at in the world. There's the University of Washington. Traditionally here, it's been Johns Hopkins with Dr. De La Centina. There's the University of Las Palmas in Spain. And there's a center in Maastricht, again, Belgium, get another, well, that's on the border of Belgium, right? But this is a multidisciplinary place where there are scientists from Belgium, from the Netherlands, from Switzerland. And, another hashtag, why not vestibular implant in the land, right? There's nothing that prevents us from being a center for it. There's a lot of work to be done, right? but we do have the strong components, we do have the strong elements, and again, I've cleared this with Dr. Honaker, but we can do that, right? And that's why, we got to think of these patients differently. We cannot dismiss every, dizzy patients, as many centers do. There's a lot to be learned in dizziness, as annoying and challenging as it might seem to us initially as otolaryngologists. I have a feeling I'm going to be flooded with dizzy patients after this talk. Quick detour by skull base. I think we're coming short on time. Skull base tumors, traditionally, not long ago, it was management surgically. Just got a skull base tumor, go ahead and take it out, right? But things have changed a little bit over time, and I like history. So the initial vestibular schwannoma was initially described as a hard body on the acoustic nerve by Sandifort in 1777. That's almost 250 years ago. We don't know who actually is the first successful removal, probably both Annandale in 1895 or the appropriately named Balance in 1892. But it is actually a native of Cleveland, Harvey Cushing, who apparently I just learned is buried not too far from here, who is the person who is the first, actually the first neurosurgeon, the first person to be dedicated to neurosurgery, and reduced mortality from 80% to about 20% with his suboccipital craniotomy, which went mastoid to mastoid. And so instead of 4 out of 5 patients dying in the operating room, it was 1 out of 5. And remember, these are the huge tumors that they diagnosed at that time. And of course, since then, things have changed a lot. We've got a lot of surgical refinements. Microscope wasn't there. Nerve monitoring wasn't there. The drill wasn't there. Do you know where the drill comes from? So Bill House actually trained as a dentist, and then he adapted the drilling. He's one of the people who adapted the drill to actually neurotology and everything. And of course, we have stereotactic radiosurgery. Over time, this is even data from 10 years ago. Look at this curve. This is the size of the tumors we've been diagnosing. So even from the 70s till today, we pretty much went, from 30 millimeter tumors, which are pretty big, to 10 millimeter tumors. And over time, you see that there are fewer and fewer of these smaller tumors that are being operated on, right? Long discussion again, and I'm oversimplifying here, but we've learned that a lot of these tumors don't grow. We know that the schwannoma is a benign tumor. We know that many of these patients, like if you look at patients with just an intrameatal tumor, there's nothing that sticks out of the internal auditory canal. 17% of them will grow over 5 years, right? And if you look at the smaller tumors, really small, less than 2 centimeters, less than 1.5 centimeters, about 30% of them will grow. Doesn't mean you shouldn't observe them, but it also probably means we shouldn't be operating on them, right? And that's where the field has changed, actually. We're having fewer and fewer surgeries. Literally, we will operate every single patient with a schwannoma went to the operating room not long ago. We have a better understanding of the molecular environments. We've all heard of Avastin for NF2. It works as a VEGF-A receptor. This is a recent meta-analysis that looked at the numbers. There's a 38% decrease of more than 20% radiologically, and 9% of patients at least have their tumor stable. These are patients who had tumors growing, so almost a 50% response. 45% have some improvement in their hearing. The question is what happens when we stop the Avastin. This is another hot off the press, single cell multi-omic analysis. And if you're like me wondering what multi-omic is, it's the study of all the components that affect the growth of a tumor. Genomics, epigenomics, transcriptomics is what gets transcribed as an RNA. The proteins that are, affect the expression of the genes, the metabolites in the cells, and the microbiome around the cells. So all these components are being looked at potential modifiers for controlling the tumors. Last stop, glomus. Traditionally, it was very high morbidity. It's a really fun surgery, but it's really bad in terms of the morbidity you can bring on patients. And then suddenly, about 7 years ago, people started publishing and said, we have these really old folks that would not tolerate surgery, and we just decided, well, we really didn't have a choice. We couldn't do anything about them. But we went back and looked at their tumors. Of 16 tumors in mostly older patients, 58% remained stable. Right. So of course they did grow at some point to get to that, but if you have an older patient, might be a good idea to just watch them. Right. Don't go and give them dysphonia and dysphagia and a trach and a peg tube. Also, again, one of those dogmas: radiosensitive tumors. We never talked about radiation for glomus tumors. It was surgery. It was, if you don't take them to surgery, what, are you not a good surgeon? Are you scared of going to the skull base? And ironically, once these studies came out, right, I was actually, I was still a fellow, and I was still training with Brackman. He looked at me, literally, I remember that, and he said, "I've been telling him. I told them since 1970 that these tumors radiate, respond to radiation. And of course, they're vascular tumors, if you think about it. That's how radiation works, right? So now there is a role for radiation. We're thinking less aggressively. We're thinking you don't need to take every single cell out. You can subtotally resect them, okay, potentially move them away from the cochlea, leave the functional lower cranial nerves, and then radiate the rest if you need to. I don't know if you've seen glomus tumors, if you've seen patients. It is, I mean, every time I have one, I'm scared because I do my best. Often we can preserve the lower cranial nerves, but once we get, even those who present with vocal paralysis and some dysphagia initially, they can just basically fall off a cliff after surgery, and it's absolutely miserable. And it's, so this is a breath of fresh air, basically, in terms of being able to consider other therapies for these patients, consider multimodality therapy. If they're really big, if they have an intracranial component, you can go in, resect it, reduce it, and then radiate the rests. Questions? I know how we all feel. That's how we all feel. Again, not exhaustive, but I just wanted to take a tour through the history of otology. Yes.
So obviously in head and neck we do other schwannomas, and oftentimes we have this. It's not a new technique, but a novel technique where we're doing obviously intercapsular nucleation, where we're preserving nerve. Do you guys do that in vestibular schwannoma?
We don't do intracapsular per se. Well, let me rephrase that. The way the surgical technique is typically intracapsular, so you reduce the size of it and then you remove the capsule. But definitely the field has shifted towards subtotal resections, right? And then we do. I think very few surgeons would just aggressively rip every single piece off. I think most people nowadays would say if it's stuck to the facial nerve, and that's a judgment call. There's no imaging to tell you that. And if it's hard to dissect, just leave it. Right? We are more conservative in leaving some tumor on the facial nerve nowadays than we are, and we used to be, and just get every single piece of it out.
But usually there's no idea about vestibular function preservation.
No. And these patients, actually the bigger the tumor, the better they do in terms of vestibular function, because they've lost their vestibular function before. So they're almost never really dizzy unless they're very small tumors. The hearing is a good question though. And I think there's more an orientation towards preserving, the acoustic part of the vestibular cochlear nerve, the cochlear nerve. But no, in terms of vestibular function, because they've already lost it most of the time. And it's worse for patients to be left with half a function, half a vestibular function, because the other side cannot compensate, as opposed to completely removing that side and let the other side compensate.
Any other questions? I have another question.
Yes.
So patients who, just as a pragmatic thing, as a non-otologist, when I see patients who seem to have some peripheral vertigo or dizziness, like what is the right thing for me to do in terms of like referring or getting them? Do I get them like into vestibular testing, audiogram, and then send them to otology or comprehensive? Like what's the right?
That's an excellent question. So any of those, basically, you can send them to us to comprehensive or start with vestibular testing. We're working on launching dizziness clinics. There's already one that's running between, Caitlin and Evelina. Dr. Honecker and myself are launching another one. It's going to be on Fridays. So we're going to try to accommodate those patients where they see everybody, and it's a one-stop shop basically, where they get their vestibular testing and see the otolaryngologist. But yeah, so we're trying to make it easy for these patients to get in and get all the testing done. I'll take applications for otology on the way out. All right, thank you.